Thanks, Daryl.
Thank you so much. Yes, thank you so much. Hello, everybody. We're so happy to be here today. I'm actually currently in Franklin, Tennessee. It's a gorgeous day, and it's so exciting to see people attending from all over the nation. So I know Patrick shares the same sentiment. We're excited to be here today, and we're excited to discuss documentation and revenue cycle and really where those two things intersect. Um, my background is actually in systems engineering, data analysis, streamlining processes. I'm not a clinical person, but I founded Hansei Solutions in 2016, having come from a revenue cycle background in the hospital space. And I identified at that time, really through a series of serendipitous events, that in behavioral health, a lot of the documentation, the process of submitting and receiving authorization, claim submission, utilization review, all of it was really somewhat archaic compared to our hospital counterparts. And I attributed, this, I guess, us being a little bit behind the curve in terms of technology and process to behavioral health really being a little bit of a newer segment within revenue cycle management, since it's only been for about 10 years now that insurance has widely covered reimbursement for substance use disorder and psychiatric services on a widespread basis. I like to say we live at Hansei at that intersection of clinical and finance. For everybody who's on this call, I think we all understand just how imperative it is for us to have compliant documentation. And we're going to discuss the reasons why the documentation is so important, not only for the purposes of compliance and protecting your center and protecting your license, but really, how does the documentation impact outcomes? How does the documentation impact reimbursement? And how does documentation impact our overall public health? So we're looking forward to exploring those topics. Just to kind of qualify us, Hansei processes about $500 million worth of claims per year, all for behavioral health. And we're really focused on the facility side as well as on the practice side. And we have relationships with all of the major payers. We're in 22 states, and we work in conjunction with providers to establish relationships with the insurance companies and to maintain those relationships. It's through our experience in processing claims, working with providers through payer audits, that we've been able to establish these relationships, and as a service organization, kind of establish rules and guidelines that are otherwise unavailable to clinicians. So we'll dive into the details.
And I'll chime in and say that thanks, Erin. And the last sentence Daryl said in the introduction, he said, simply put, Hansei enables providers to collect more, save more, remain compliant, and make informed decisions impacting their growth and bottom line, which is the goal, right? Run a more efficient business, get paid what you deserve, and stay compliant. And like Erin said, the reason we did it is so the collaboration of all our work, experience, and history from on my side, from being an operator and going through licensing, going through credentialing, and working with insurance companies. Erin's side on the data, we were able to finally crack the code, as it said, and it feels like that as a clinician and as an organization sometimes. Like, what do they want? Like, how can we do this right the first time instead of going back and forth and like that? And we feel really good that we've been able to do a better job than anybody when it comes to learning that stuff. Behavioral health's like no other business. It's not even any other healthcare, where you know what you want, you know what you got to give them, you know what you're going to get. Behavioral health's different. And so, our goal beyond running a business is to increase the knowledge of the space. And that's why it was so important for us to partner with TPN to help give people the rules, because the payers don't always give them to you. So our goal is to raise the awareness to help people stay compliant. Go ahead.
Thanks, Patrick. Sure. And then just kind of like some housekeeping items just to cover. We want this to be an interactive session. I have experienced death by PowerPoint myself, so I think that it's important that this is interactive. We only have 13 slides, so a lot of the information will be delivered verbally. And we want to make sure that you can use your raise hand feature in the webinar or the chat feature, and we will be pausing periodically after each segment so that we can answer questions and kind of have a more engaging approach to today's experience. Okay, and by the way, my screen is over here, so if I'm looking over here, it's just because I have 2 monitors. Okay.
Was as well. And you're right. So if anyone would like to speak during the presentation, ask a question, you can go ahead and click the raise hand feature at the bottom of your Zoom webinar controls, and then we can go ahead and allow you to talk. But it looks like as we're speaking, Darren is raising hand. Right. Shall we, Patrick?
Yeah. Do I have to do anything, or can he fire away?
You can fire away. Darren, if you like, you can unmute your mic. There you go.
First of all, thank you guys so much for doing this and breaching the topic. My question is, if you are a clinician who is starting his own business or thinking about starting his own business and you're one employee, could you guys really help somebody who is an army of one get through the weeds of billing and actually getting paid? Because one of the things that stops me from starting my own practice is the 6 to 10 month delay on reimbursement from anybody in Medicaid or other insurance companies, period.
I think that's a great question. Thank you so much for posing it to the audience, and I think we'll be able to cover some of this stuff. So to answer the first part of your question, I do think, and right now more than ever, we're seeing more and more clinicians kind of branch out and begin operating their private practices. Now, what I'm also seeing in the same breath is a lot of clinicians have a fear around insurance reimbursement, and they opt to choose a private pay model and then deliver it to their clients or their patients a super bill. And some patients are afraid of insurance as well, so they're afraid of going through the super bill route. What I will say is that I think the best model for an individual practitioner or a small practice or even a large practice is to make sure you're working with an expert to templatize your EMR system. So everything is really going to boil down to what type of assessments you're using, what your treatment plan templates look like, making sure that you're following the appropriate criteria for continued stay, depending on what services you're rendering. And then really for, individual and one-on-one sessions or family sessions, ensuring that your template, your documentation template is covering everything that the payers want to see inside of that note. And we actually have an example of such note in this presentation, so we'll be covering that. Now, the second part of your question regarding reimbursement and kind of what that runway looks like, the timeline from opening your doors to becoming in network, that could be that 6 to 8 months that you're referencing. So the timeline from when you open your doors to when you're actually contracted with the MCOs for Medicaid, or when you're a Medicare approved provider, or when you're in network with your local Blue Cross, that could be lengthy. Now, from opening your doors to being able to receive reimbursement from PPO policies for those out of network patients, that is much shorter. So we really, once you've established a steady state and the payers know who you are, we would be looking at a median reimbursement of about 21 days. So I hope that's helpful. We're going to dive into the presentation. I want to make sure that people can continue to raise their hands. And then what we'll be doing is we'll be taking a quick break after each segment, and we'll run through any questions that have come up for that first segment. So our first topic today really is going to be on identifying 2 strategies to improve relationships with insurance companies. Afterwards, we'll be diving into 3 additional topics: best practices for billing and optimizing reimbursements, understanding the steps of a clinical documentation audit. This one's pretty lengthy. And then explaining really how we tie all this together. What is the role in billing practices and in documentation, and how does that have a consequential impact on public health? I've got a quote up here. I think this is really important, and it's something that we reiterate regularly. With the providers that we're contracted with, I would say that on average, we are going in and we're probably needing to do a documentation refresher on a quarterly or biannual basis. So we have this quote that we see a lot, and that is, if it's not documented, it didn't happen. And this is not our position. This is the position that the payers take, and this is the position that the regulators take. So we are the messengers of this and want to make sure that we're always reminding clinicians, we're always reminding facilities to be really detailed in that documentation, and we're going to give some examples. Okay, so here are 2 strategies to help improve relationships with insurance providers. So I'm going to kind of start off with one, comment. So we've got contract negotiations as one strategy. As our second strategy, we're talking about utilizing data to provide actionable insight to treatment. So on the one hand, we're talking about relationships with insurance companies, getting in network, being a preferred provider inside a payer network. And then on the other hand, we're talking about, okay, how can we measure the data on improvement or on outcomes, improve clinical outcomes within our ecosystem, with our patient population? How can we measure that? How can we document it? And then how can we take it back to the payers? So ultimately, overall, the insurance company's customer is really the employer who is contributing to these health plans, or the actual end consumer who would be the patient who is buying health insurance on the exchange. So their customer is not the provider. We are not the customers. Their customers are really, a lot of the money is coming from the employers, and they want to appease those employers' relationships for the self-funded plans. And then also, of course, the end consumer, which is the actual patient who is subscribing to this insurance. So that is who their customer is. They're kind of on this balancing beam of keeping their customer happy and then also reducing costs. So we know ultimately the insurance company's overall objective is to spend less. Now, the way that they spend less money is by having a healthier patient population. For us on the behavioral side, the way that we can promote and show a healthier patient population is by measuring outcomes. So how does our treatment, how do our clinical interventions, how does our facility or our practice, how are we directly contributing to an improvement in patient health, which then is going to reduce the payer spend? So Patrick, I know that you've got a whole lot to say about this.
I love outcomes. So from when you start working with the patient until when they leave, right? That would show the efficacy of your service, right? So any improvement that has to do with then is, as a result of your service. And we want to show improvement in qualitative. So the quality of life is a good measure that comes from, something that NATAP supports. So quality of life looks at about maybe 9 or 10 domains of somebody's life, not abstinence, right? You're looking at reduction of behaviors that aren't beneficial and increasing behaviors that are beneficial, right? So you want to see somebody back to work, you want to see somebody social, you want to see them have a support network, you want to see health increase. So from an insurance company, you'll look at the efficacy of when somebody started and when you leave. And then the goal is to stay connected with people longer, right? And then, so my goal, if I'm going to treat somebody, is going to be to stay connected with them a year post-treatment. And in that year post-treatment, you're not only going to show the efficacy of your service, you're going to show how your services continues to improve their service. And so when you go back with those outcomes, that's when you can leverage better rates, or potentially, as we start to step into the idea of value-based contracting, those are going to be really important. So 2 scales, pre and post your treatment, and then post your treatment, how they continue to improve. But Erin's right. We want to show that we're creating and supporting a healthier individual, and that the insurance company is going to spend less overall by paying for them to come see us.
Right. And I think that this is also the cornerstone for how to improve those relationships with the insurance payers. It's like a lot of times insurance is really tricky. I think it's purposefully complicated. There are a lot of nuances, particularly in behavioral health, because we don't have a single standard like CMS or the AMA, because each insurance company kind of has their own set of rules, which we'll be discussing. But even though it's tricky, ultimately we all have the same intention, which is to improve the health of the population that's being treated, whether it's their mental health or their physical health, and really a combination of both, because we see so much overlap there. So if we can show that we're improving that health, that will help encourage a better relationship and even establish relationship with the insurance payer. The other thing is we would do is we could take that data and approach the insurance company with that information for our contract negotiations. So I think I saw some people highlight that they're in Texas. I'll use Texas as an example. In Texas, if we approach Blue Cross Blue Shield of Texas as a solo practitioner or as a facility, and we want a network contract, they're going to give us a rate, and that rate is predetermined. Everybody gets the same basic starting rate. Everybody starts at the bottom. And then when you go back after a year or 3 years, you have the opportunity to renegotiate. And it's at that time of renegotiation that we would want to show those in treatment and post-service outcomes, try to advocate for a better contractual arrangement. So that's one of the ways that we justify contracted rates requested during the negotiation phase. The other thing that they're going to look at is they're going to look at things like readmissions. They're going to look at post-discharge emergency room visits or post-treatment ER visits. They're going to look at, infectious disease. They're going to look at ICU stays, and they're also potentially going to be evaluating the strain on society. So what we're really interested in measuring is how all of those things have been reduced as a result of our interventions and our treatments, and then to have a really good mechanism for documenting such. So there are a number of ways to do this. A lot of people make outbound phone calls or have some level of peer engagement that keeps the patient inside of the ecosystem and allows for us to continue that dialogue. I know Patrick says, like, we can't measure an outcome unless we first have that patient engaged. So it's really important to kind of focus on that overall engagement.
Yeah, and a baseline is always really important. So the baseline of when they start your service to when they leave, and these are also results that you can do more for just outcomes with the payers. This is stuff that you could, you could publish. This is stuff that could be in a journal article. This is stuff that you can, brag about if you see consistent improvement. And it also gives you feedback to your own service. Where do I need to improve? What types of patients do I do better with? And so it really helps. And remember, as a clinician who went through tons of school, we don't get taught or learn how to document the way that payers want. Payers like quantitative, right? We as clinicians like qualitative, right? But it's really hard to measure qualitative, right? That's why we like the outcomes, the pre and the post. They love the data, they love the numbers, they like it black and white. They don't really care about the long narrative about, going through the whole, traumatic stuff. Although that's super important and we have to document it, that's not how they're making decisions, right? They like to make decisions with numbers and quantitative. So the more we can do that in addition to the qualitative, the better off we're going to be.
Thanks, Patrick. And I do see a question, Darren. Is there a method of getting paid for post-service checkups and check-ins? More and more, we are seeing coverage for what we would call a peer support encounter. A peer support encounter is defined as a 15-minute encounter that is made between a patient and a peer. So that person they usually would have some type of certification for the state that the services are being rendered in, but it wouldn't be a license. It wouldn't be a master's level education. It would be some type of a certification as a peer support coach. And those check-ins are billable and reimbursable by most commercial insurance policies. And also, we're seeing a number of pilot studies being done for these peer engagements as well. The second thing that I want to touch on, just to kind of circle back around to these insurance relationships, I think that, and this is kind of just like, I don't know. I think that it's important. And like, we always advise as a third party, we are a third party service provider, we are a vendor. But when we are assisting facilities or providers with securing contracts, we always want them to be the face of those conversations. We have seen the best results when the insurance companies know who you are, when you have a relationship with a representative in the department, where you are passionately advocating for yourself, for your program, for your practice. So we would always encourage that your third party kind of stay behind the scenes. You could have somebody, who helps with all the administrative credentialing stuff. But when it comes to them knowing who you are, it's like applying for a job or applying to college. You want something special to stand out about your application. And we really see that element of uniqueness, that, distinction is best conveyed by you folks as individuals versus third parties. All right, so I'm going to go ahead and pause here. We have, after this, we're moving on to the next topic, which is billing best practices. So I want to go ahead and take a pause here for any questions.
So here's some stuff in the chat. And I'll answer this too. Can you explain a bit more what you mean by qualitative? So qualitative describes the quality of something in words, narrative, right? So it's kind of opinion, right? It's subjective, whereas quantitative looks at numbers and it's objective. So it's easier to quantify something because you can say on a scale of 1 to 5, how do you feel, how do you feel that your appointment was today? 4, right? So it's a hard number. So the more we can do quantitative in behavioral health, the more that we're going to have a little more leverage with the payers.
Yeah, so instead of, we want to be able to measure everything. So we really like seeing anxiety on a scale of 1 to 10, depression on a scale of 1 to 10, cravings on a scale of 1 to 10, being able to just assign a metric to everything.
And Erin was talking about the templates. A lot of templates will have you, if you're not already using those, and then some of the EHRs do it too, where you're quickly kind of going through and screening these people at the session for those things. So you don't always have to put it in the words, you can set it up to where it says, how coherent, anxiety, and just boom, 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 boom. So you can quickly do it.
Okay. Yes. I'm just answering the other question. It is effective using scales in the notes such as PHQ-9. So yes, absolutely. I think that's a perfect example of what we mean by qualitative assessment. And then from another person, we have a question regarding even if I'm still in network, and I think that this is probably in relation to the outcomes. Yes, even if you're in network, we want you to measure outcomes. And the reason is because when you establish that in-network rate, we would expect as a vendor to see your rate increase about 3% year over year. So if your rate is $100, year 2, we'd want to see your rate be $103. Year 3, we'd want to see your rate be 103% of $103. The way that we can best position you to advocate for a better rate and to receive those annual increases is if we can circle back to the payer and say, hey, listen, we're already in your network. We're a participating provider. First of all, we want to be, a center of excellence. And second of all, we want to be able to leverage our outcomes in order to negotiate a higher rate. And thank you so much for the explanation. The question is to the in-network follow-up. If you accept insurance but want to transition to private pay, can clients be provided a super bill for reimbursement from their provider? Okay, so there's, it depends. Usually if you're in network, you would not be able to provide your clients with a super bill. So generally speaking, and this is really going to be based on your contract, but generally speaking, if you're in network for a service, you will not be able to charge patients who have that insurance a private pay rate. You would only be able to charge them at the most the contracted rate, and they would have to pay for their deductible or their copays. So yes, in the event that you are in network with a payer, so if you're in network with BCBS of Texas and a patient with BCBS of Texas comes to you for services, you would not be able to charge them a private pay rate. You would be limited to charging them the in-network rate.
But you
as
can
part of
be
your contract.
in network with BCBS and out of network with Cigna and Aetna. So
yeah. So it depends on
it's payer by payer.
Exactly. So I hope that's helpful. All right, next we've got billing best practices for optimizing reimbursements and revenue. So we're going to kind of go through examples of 3 areas. Number 1, the documentation of medical necessity. Number 2, following payer criteria. And number 3, making informed admissions decisions, or in the case of a private practice, making informed, treatment decisions on eligibility and verifications. So documentation of medical necessity. I mean, this is all of this stuff. This is kind of showing how documentation is the cornerstone of everything else downstream. So the documentation is, first of all, going to allow for your services to be coded appropriately, so that, let's say you are a physician. You want to make sure that if you are seeing a person in your office visit and you're delivering a level 4 service, that it's being coded as a level 4, not as a level 3. So that's an example for a physician or a doctor. Now, if you are a therapist who's working at an intensive outpatient delivering substance use services, the documentation is going to be the backbone of the service that's rendered, but it's also going to be what substantiates medical necessity for that service. So, we've talked a lot about improving patient outcomes. I think categorically, we probably are all in agreement that a longer duration of services promotes a better outcome. So in order for us to make sure that we are giving our patients the best shot at having a successful outcome, usually it's recommended to maximize the amount of treatment services that they receive, or the duration of such services. So if we have a patient who comes in and they're being seen in an intensive outpatient setting, but all of the notes are focused on the improvement and there's not enough to support a lack of stability, we're going to have a really tough time showing medical necessity for continued care in an IOP setting. So the documentation becomes the foundation of the utilization review team being able to get those services authorized. So one of the things that we focus on when we do documentation trainings and education is we want to educate providers that we, of course, want to show the improvement. We want to show how somebody is going from a 1 to a 5, but we also want to show that they're only at a 5, they're not at a 10. So being able to show those measurable improvements, but still ensuring that we're capturing everything that shows what they still need to work on, where the gaps are, so that we can best advocate for that patient if they are indeed still requiring services and meeting medical necessity. So, it's always our mission that the appropriate level of care is being rendered for that patient to treat that patient's symptoms. And the documentation is essential in being able to substantiate those services, so that your utilization management team can best advocate for the patient. So I think that's kind of, fundamentally where we see the documentation of medical necessity. This also doesn't only come into play for utilization management. This really comes into play also for post-payment audits. So, it's not unusual for Cigna or United Healthcare to come back a couple years later and say, hey, listen, we paid you for, 180 therapy sessions back in 2017, and we want to see those charts now. So, we have to produce these post-payment charts, and they're going to be going through the charts to make sure, or to do a sampling to see that the services indeed were medically necessary after the fact. So it's important for authorizations, and it's also really important to protect your revenue for post-payment audits. Patrick, do you have anything there?
Erin, did you go over the Payor criteria on the?
Nope. I've only done the medical necessity.
Oh, okay. Well, I think that's
number one
in the Payor criteria.
Yeah. Now, Payor criteria is a little bit different. So when we're thinking about documentation, we're kind of in two schools. We've got one, which is the medical necessity criteria, which we just discussed. Does the symptomology of the patient meet criteria to substantiate their need for services? And then the second school is the intensity of services. So that's going to be, what is my program, or what is my treatment, or what does my note need to look like in order for it to meet the intensity of services that the insurance company requires? So this is where it can get a little bit tricky. I'll use partial hospitalization as an example of this. I don't know how many people in the audience work with a partial hospitalization program or have been involved in delivering PHP services, but partial hospitalization, we see different intensity of service criteria across insurance companies. Oh, that's a great question that we just had come in. I'll get to that in a second. So Cigna, for example, may require 4 hours of programming a day for PHP. And I'm using these as an example. These are not specific to Cigna. And Cigna may require that the patient is seen by a MD within the first 24 hours of admission to a PHP program. Whereas United Healthcare may say, no, we need to see 6 hours a day for PHP, and they need to see a physician within 72 hours of admission. So that's a perfect example of where you'll have two insurance companies requiring two different things for the same levels of care. Now, where it becomes really tricky is when United wants to see one thing, Cigna wants to see something else. Then you've got the Joint Commission who has a third set of standards, and then you've also got your state standards. So what happens when these things conflict? Usually, our rule of thumb is to follow the payer criteria, because generally speaking, the payer criteria will be the most stringent. So usually, in most instances, if you're following the payer criteria, you will be overachieving for your state and your Joint Commission criteria. Now, how do we know what this criteria is? One of the questions that just came in is, as an out-of-network provider, how can we find out what the payer criteria is? Well, I'll even take it a step further. How do we find out as an in-network provider? I mean, most of these insurance companies do not publish their criteria. Most of them, when you become in-network, they don't necessarily send you a manual and says, this is every single thing that we want to see in order to substantiate your services, in order to meet the intensity of services. I usually have found that United Healthcare and Cigna are actually pretty good about making available to the public through their website and through online resources their intensity of service criteria. That's exactly how I would Google it too, is intensity of service criteria or medical necessity criteria for behavioral health providers. And they'll take you to their website, and you can usually find a manual. Cigna releases a manual every year that outlines that criteria. We have found as service providers that the best way for us to really gain an understanding of payer criteria is simply through experience. In the last 8 years that we've been open, we've worked through hundreds of payer audits with the providers we're engaged with. That experience in working through payer audits and really understanding the nuances of each insurance company has given us the ability to document what the requirements are. And we've been able to come up with about 13 different sets of criteria that vary by payer, depending on what the level of care is, whether it's mental health or substance use. And then in the event that you don't have access to a third party who has that knowledge, or if your in-house team doesn't have that knowledge, we would really default to the locust criteria for mental health and to the ACM criteria for addiction. And then the next step down would be defaulting to the state criteria. So I hope that's helpful. The other thing that you could do is you can email the insurance company. I think that kind of ties back to our first slide. It's like, we want you to be visible to the payer. They want to know that you're being proactive and that you're interested in being compliant. And I think it's a really good idea to try to really nourish those or nurture those relationships. That last piece on this slide is make informed decisions. So this is really going to be tied directly to revenue, eligibility and verifications, and then also a little bit to utilization management. I don't know how many people, I saw somewhere in the audience that we've got someone from Charleston, South Carolina. So South Carolina is an interesting one. So for anybody who's worked extensively with South Carolina plans, you'll know that we could get these policies that come in and they're BCBS of South Carolina, and the benefits look fine, the deductible looks fine, the out-of-pocket maximum looks fine, the co-pays look reasonable. But if you're delivering services that require an authorization, those outsource to a carve-out called companion benefits, and companion benefits, CBA, is really, really, really tricky to get an authorization with. So, utilizing your history with a payer, having somebody analytical on staff who can run through your financials and see how you've historically been reimbursed or look at those historical denial or payment patterns is going to be your best evidence of future reimbursements. So as you're evaluating people for clinical appropriateness to your program or to your practice, there's also an evaluation for financial appropriateness. And this is where we want to see that, yes, the person has benefits that cover your services. Yes, they're able to, cover their patient responsibility piece for the deductible or the copays. And then third would really be how has our relationship with this insurance company looked historically? If we historically have had a 50% denial rate, then our best prediction is that in the future, we're also going to have such a denial rate. And then I would also say, hey, give somebody like us a call so we can kind of dive into that a little bit. But we're going to want to really be utilizing the historical data to help drive those decisions on a go-forward basis. Does anybody have any questions there regarding these 3 best practices for optimization of reimbursements and revenue?
I would say the
Any
biggest,
questions
the
that-
biggest part of this is documenting the way that payers require, not the way it should be, which is for me personally, it was hard to get across, and knowing that payers require different things. So once you get into, bundled rates for IOP and PHP, there are a lot more nuances.
Yeah, and a lot of this stuff is finding somebody who has the experience of working through payer audits. Okay, we've got, Maxine, that's a great question. What about reimbursement with straight Medicaid? With straight Medicaid, your rates are going to be flat. So the rates are predetermined based on that MCO. And then also with Medicaid, usually the patient doesn't have any financial responsibility. So with a Medicaid admission or a Medicaid evaluation for financial appropriateness, it's really binary. It's a yes or no. And then what happens is where Medicaid, we see the biggest impact is infrequent denials. So I think that on the Medicaid side, we'll see that on the commercial side, it's the same CPT codes that we use for commercial payer are not necessarily the same CPT codes that Medicaid is accepting. And there are some codes that are specific to Medicaid. So generally speaking, on the Medicaid side, if we're seeing reductions in revenue or in reimbursement, it's as a result of denials, not as a result of lower reimbursement. So on the Medicaid side, in evaluating your historical information, we're going to be looking for denial patterns and denial trends. And then we're going to be doing a root cause analysis on those denials to see if it's a coding issue. Different MCOs in different states have different guidelines as to for how they want to receive the claims. So, a MAT service with a drug test and intervention and, a Suboxone induction is going to be billed to Medicaid differently than it would be billed to a commercial carrier, as an example. It's a very good question. And
keep on trucking.
Yeah, and it looks like we're going to go ahead and link the handouts right now in the chat for everybody. Oh, one other thing, I didn't touch on this. This is very important. Forms. So this is in the bottom right of the slide I'm currently on. Don't let an unsigned form be the roadblock that prevents you from getting paid. So we want to sign your forms, but not only your documentation notes. So not only, signing off on your treatment plans and making sure the patient signs off or signing off on your individual session notes, but upon intake into your program or practice, it is essential that you get a certain form set signed by the patients. We're going to usually, best practice would be for every patient to update their coordination of benefits, especially if they're, if they're commercially insured. The second thing is if you have an Aetna patient, Aetna has an authorized representative form that you're going to want to have them sign. United Healthcare has an authorized representative form that you're going to want them to sign. So get these forms signed, because in the absence of these forms, it's really difficult to appeal on the back end. We'd also recommend an assignment of benefits form to be signed for all of your commercially insured patients. So just to kind of review those: and coordination of benefits update, an authorized representative, and then an assignment of benefits form. Okay, this one is probably where we have a lot of content and we may have a lot of questions. We're going to be kind of diving into a documentation audit. So there are two types of audits that we would see. And what we're going to talk about first is just the practice of really auditing a clinical record, just a routine internal quality audit, and what steps we would see there, how many times we're getting eyes on the chart before it's closed out. And then the second thing that we'll talk about is actually how to handle and how to navigate a payer audit. Okay, so this is just a very simple 4-step approach to a daily and weekly chart audit. So this would be done internally. These are best practices for quality, and this is what we would expect to see internally on the compliance side. And also what we would need to see, in order to substantiate the claims from a billing end. So once again, this is sort of like the gold standard. Step one is going to be that internal clinical audit. So making sure, whether you have somebody in a quality function, or whether it's you, or whether it's the clinical director, making sure that that person, whoever kind of owns this realm, that this person is going through the charts for each patient on a daily basis to ensure that the documentation is complete. Making sure that group notes have signatures, the treatment plans have signatures, the individual therapy notes have signatures, and that there's also some, if a supervisory signature is required, that those signatures are on there. If a review signature is required, that signature is being captured. And really what we're looking for also is making sure that the appropriate number of hours are included. So, if it's an IOP day, we'd want to see 3 hours of programming for that day. And then in addition to that, we want to see that they attended at least 3 days per week. I would say that, because there are some weekly requirements as well as daily requirements, being able to holistically evaluate the chart on a weekly basis is really probably going to reduce redundancies in your workflow the most. So we go back and kind of do a look back 1 week at a time to make sure the patient notes are all in there and that it's meeting criteria both on the daily and on the weekly standards.
And I would say, so the majority of stuff that you can easily do is hours, right? That the hours in a week match up to what you're billing. When it comes to the kind of the qualitative part, usually that's not going to get scrubbed, unless there's an issue. But the biggest thing that we see is that the services you provide match up to the services you bill. And the easiest one for that is, hours, or that you're starting and stopping in a time that is to what you bill. Not that you're meeting with somebody for 30 minutes and then charging for an hour.
Correct. Yeah. So this is kind of step one, would be the internal audit that your quality person or your compliance person or your clinical director is completing. So this is your internal audit. And like Patrick said, a lot of this is going to be quantitative. So just making sure that we can kind of cross off the boxes and less of a deep dive on the actual content of the notes, but just making sure that we have everything there to actually substantiate the claim. Step two would be the second pass at the audit. This should be done by your medical biller. So anybody who is coding these claims, who is reviewing, who is submitting insurance claims, they should be looking at the chart, reading the material, and ensuring that the appropriate number of hours have been completed. So we see a lot of people coming to us where they've had a historical practice of billing based off of an attendance log or based off of a census. We advise against this. I mean, all billing best practice includes some mechanism of coding the claim. Now, on the behavioral side, for facility-based services, a lot of that coding is going to be based on whether or not the content includes all of the programming hours and components that need to be available. And then, on an individual therapy side or a group therapy side or like routine outpatient or ancillary services, we're going to be really just taking a deep dive at that specific note to make sure it hits all criteria. So step one, we've got the in-house audit on the quality side. Step two is going to be audit at the time of billing or at claim submission. This is really important, and it's something that we really see that is often missing in a workflow. Whereas in every other part of the medical space, it's not missing. Like if you go to an orthopedic surgeon, you're not going to find that their billers aren't reading the claim. They're reading the medical record because they have to code that claim. We want to see that same level of attention in coding your behavioral health claims as well. Step three is basically just a piggyback off of step two, but is actually, step two and three really do go together. So we're going to be coding the claim and reading the documentation at the time of coding, and then also at the time of the claim submission. And then step four would be the discharge. So best practice would be that if you are operating a facility-based program, or if you have somebody that is leaving your practice, that there is some type of a chart review before that chart is closed out. So, once again, the quality person, the clinical director, or your compliance person, whoever's role it is, we want to see that there is a formal process in place, a policy around closing out the chart. Now, some of these things that I've discussed, there are ways to use technology to help assist you. So we have had the pleasure of working in some EMR solutions and even creating EMR solutions that will prompt the user to follow these steps, so that there is some prompt that reminds you that you have a treatment plan that needs to be updated, or a prompt that reminds you that a group facilitator has not closed out a note, or a prompt that reminds you to complete a chart audit at the time of discharge. So there is a lot of opportunity here. If this stuff sounds overwhelming, there are a lot of technology solutions available that can help facilitate these, workflow tools that can help prompt you as an auditor or as a compliance person or as a clinical director on how to make sure, and kind of just to have a reference point of what needs to be accomplished in order to deem that as complete. All right, now here is an example of a bad note. I mean, we're very basic here, really broad strokes. So we're just going to kind of go through. This is a real note, of course, that has been why can't I think of the word? Redacted. This is a bad note that has been redacted, and we're going to kind of just go through the documentation if you can't see it. So we've got, the client demographics up here. We've got the date, time in and time out. Very important. Session start time and session stop time. Sessions are time-based coding, so we always want to have the start time and the end time. What the primary problem is, which is the principal diagnosis code. And then it says, client describes multiple relapse experiences of having received treatment for substance abuse followed by a return to his drug of choice. The client has been unable to maintain sobriety after leaving treatment. The client displays emotional reactivity and has been identified as a risk for relapse. The interventions implemented. The client was assigned to write a chemical use history describing his attempts at recovery and the situations surrounding his relapse. The client has not completed use history and the situation surrounding relapse, so we were unable to process the information. Then we see the relapse pattern with a client with a quote, early warning signs of relapse as an exercise that was assigned. And then we have the observation that the client remains at a high risk of relapse and that the client requires more time to learn skills to remain sobriety. So some things here. Okay, so we've got the counselor. The counselor in this case was missing credentials. You can't see that on this, but because it's been redacted. but we want to see that once it's signed that, you know, as therapist or counselor, that your specific credentials are also included in that signatory. So the counselor is missing credentials. The note is lacking clinical detail. The observation should include a mental status exam and the activities of daily living. The interventions are not completed. And it should also show, it should follow a GIRP or DAP format. There's no information regarding client response to the interventions, and the type of session is not clearly identified. So it just says progress note. So what type of progress note is this? Is this a therapy progress note? Is it a one-on-one? Is it a one-on-one therapy session? Psychotherapy? Is it a case management note? That's just not clear in the title of the note. This is a gold standard note. So you can see here, there's a lot more detail. The session includes start and end time with the duration. So we want to show the start, the stop, and the duration. So begins at 2 o'clock, end at 2:50, duration 50 minutes. Now the duration you would think is pretty obvious because we could just derive it from the start and stop time, but these insurance companies are pretty finicky. So we kind of want to see the start, the stop, and the duration. We had an experience where it said duration 1 hour, start time noon, but it didn't show that it ended at 1. And even though the clinician signed off at 1, we were still, you know, it was still like listed as a mark or as a deficiency during an audit. So start, stop, and duration. This kind of ties back to what Patrick was saying as far as the quantitative assessment is concerned. We've got ratings of cravings, anxiety, and depression. So you can see up here on a scale of 1 to 10, the patient has rated their cravings at a 7, their depression at an 8, and their anxiety at a 7. So if we see, you know, we want to see how does this compare to last week, and then next week, how does it compare? So we can start trending that improvement or regression. The type of session is clearly documented. So I can see it's a progress note, clinical, and it's an individual clinical progress note. There's a mental status exam that has been completed. So you can see that right, you know, up here, the mood, demeanor, affect, and SI. We've got the ADLs that have been documented. I also see down here, we've got some physiological symptoms of post-acute withdrawal. This is, you know, in addition to the ADLs. So this, you know, person hasn't had trouble bathing, and then they're still experiencing sweat, anxiety, restlessness. These post-acute symptoms, if you're working in a substance use environment, are incredibly important. A lot of this information is what we use to actually get continued stay for authorization. We also have the barriers to treatment clearly identified down here: lack of sober housing, dual diagnosis. And then we've got the GIRP format, which includes lots of clinical detail. And the problems in here are directly linked to the treatment plan, which is also incredibly helpful. So I've got the treatment plan items right here in the bottom left of the note, and I see how this note is relating to problem 1, anxiety, problem 2, bipolar, problem 3, relapse proneness, and problem 4, substance use disorder. So making sure that our interventions and our work is directly tying to that treatment plan is essential. And it's a really easy area to kind of get caught up on during a clinical audit. Going back to, I was just flipping ahead, but I'm going to flip back again. So this all kind of touches on what our daily and weekly chart audit should look like. So these are going to be the audits that you are doing, that your third-party biller is doing, what's happening in the moment while treatment is being rendered. There's a different process that we would see when you're really working through a payer audit. So payer audits, we're going to be looking at the same things, but payer audits are usually after the fact. So where records are being requested after payment has been distributed, and we're having to go back and then go through the notes with a fine-tooth comb. So it would be the gold standard that all of your documentation is being audited as the services are being rendered, so we can really protect your revenue and protect those relationships with the insurance companies. Because when that time comes, and it's not an if, it is a when you receive a post-payment audit request where medical records are being requested, the insurance companies are going to be going through this exact same detail, and we want to make sure that it has been addressed proactively on the front end, so that we're not needing to engage in a corrective action plan or try to mend a relationship with an insurance company to show that improvement going forward. So at Hansei, what Hansei means is that we reflect on those problems, we learn from them, and then we do better going forward. And a lot of these standards we've developed because we've had the opportunity to work through audits. We've worked through audits where things where the documentation was subpar. We've had to engage in corrective action plans. We've had to, hold the hands of the provider and the payer to get the provider back in the insurance company's good graces. And it's through all of those experiences that we've been really able to fine tune exactly what documentation the payers are looking for. Here, I think these are going to be your ACM dimensions, and we've got AACP. These are just examples of state and national regulations and resources for following, what standards should be used. So we kind of touched on this before. Payers by and large are not publishing their requirements. So in the absence of published requirements, and in the absence of an industry expert that has that knowledge database, we want you to follow ACM standards and your state standards. Can you hear me, Patrick?
Oh yeah.
Okay, I've got to change my audio. It looks like I've just lost my headphones.
So promoting public health, how billing practice and clinical documentation play a crucial role. So to be able to document and get the services for clients is efficacy in the program. It's access to treatment. People that are insured deserve the right to use their insurance for these services. And these are the rules that we have to play by to get them the access to those. So when you talk about promoting public health, unfortunately, where I am in Charlotte, there's been a lot of teenage suicide lately, and so whenever it happens, everybody always says after the fact, oh man, yeah, we're going to start talking about it more, or we're going to start, it's always afterward, when the truth is access to services, after you need it, after something happens, but access before, understanding that you can use these benefits, like it's healthy to use these benefits, is really promoting public health. You don't have to wait till the ball drops to get help and access service. You can do it and your insurance company will pay for it. As long as we, check the criteria and get them approved correctly.
Yeah. So, I think, we've got some ways here. So, the documentation, I think what we're seeing is that the clinical documentation and that notion that if it's not documented, it didn't happen, is an accountability tool that the insurers use to make sure that they're paying for things that are actually happening. And, we work really hard on the advocacy side to make sure that there isn't an overreach in what's being requested by payers. That's a lot easier said than done. At Hansei, we've seen, denial trends that exist with one payer that we're not seeing with another payer. We've seen denial trends with peer reviews. We've seen instances where peer reviews are being conducted by physicians who are not specialists in addiction or psychiatry. And these are, injustices that we believe are happening that are not leveling the playing field. And we spend a lot of money and time and resources and advocacy and lobbying to try to make sure that the insurance companies are also being held accountable. But, overall, the documentation is going to protect you as a provider. It's going to protect the facility, and it creates that accountability so that we can reference back on something and understand, so that if the person has to come back again, that we have that, baseline for treatment and for delivering good treatment. The other thing I have on the far right is for the research and outcome measures. It's like all of this data, being able to measure the improvement, being able to measure how a patient is doing and how your interventions impacted them while in treatment, and then also post-discharge. This is just going to produce better outcomes so that we can, get better rates, and then we can increase access. So, a lot of times we'll hear that only about 10% of the population who needs behavioral health treatment is actually receiving behavioral health treatment, that there aren't enough providers, that more people need help. And there, like Patrick said, there may not be enough access points. And this is particularly the situation that we see in rural areas. And we want to make sure that we can provide resources and that we can collaborate and that we can share this information so that we can increase access.
Yeah, and I would say you always want to gauge, obviously we talked about this, gauge the client, how they react to the services that you provide. But I would also say you also want to engage employee satisfaction, because that's how you provide service. So you're gauging how satisfied your employees are, and any opportunity you can to improve your service. And then you're gauging the result of your service by doing outcomes from the clients.
And then I think, in the middle, we've got legal protection for the provider. I mean, I think this goes, I think it's pretty clear, and we all know this, but knock on wood, it doesn't happen. But if in the event of a sentinel event, a reportable event, you'll be needing to contact the Joint Commission or, your regulatory body. And we want to make sure that those patient charts are all buttoned up, so we have a really, really good idea and a chronology of all of the services that the patient received while in treatment, what their symptomology looked like, how they were improving. It's just that we have everything all bundled together and buttoned up for production for those agencies. So
Yeah,
it's also really important for, protecting your license and from a liability standpoint.
And unfortunately, stuff happens. We're working with people that are really definitely struggling in some areas. The licensing boards are going to hold you accountable to your own policies and procedures, and your policies and procedures will all obviously line up with the compliance, but they're holding you accountable to what you say that you're going to do. So that's why it's always important to kind of audit yourself. Am I doing this assessment within the 48 hours of admission? Am I doing this? Am I doing this? Because you want to be in good practice just in case something like that happens, because you don't want to wait until something like that happens.
Here are a number of resources. So I know that we have circulated the link to the slides in the chat. This actually has some of those resources available for the intensity of services and the medical necessity guidelines that we were referencing. So we've got, Aetna, ACM, we've got Cigna, Magellan, provider resources. We have public health resources available here. And then we also have documentation guidelines through additional organizations such as Locus for mental health. So these are some really, really good resources that we've used at Hansei for kind of compiling our manual and our knowledge base around these documentation rules. I'm hoping that through the course of this presentation, we've been able to outline how documentation really is the foundation for everything else that's happening in the treatment environment. It's really kind of like the heartbeat of the treatment program. You guys are delivering the services, but the only way that anything else can happen is if those services are being documented. It, directly impacts your reimbursement. It impacts your relationship with the insurance companies. It's going to be that baseline for establishing clinical outcomes. And then overall, strong documentation is going to have an impact on improving overall public health. So, I'm hopeful that all of this was tied together. I think we've approached the end of our presentation, but we do want to reserve these last 15 minutes
for questions and comments and for engagement from the broader group.
Yeah, please, ask some questions. And I think kind of talking about why we were so motivated to partner with TPN, because we really felt like TPN had that national outreach of practitioners all over, and so for us, we know what we know, but we want to know more, right? And we want that feedback. We want to partner with people in more areas, providing more services, so we can continue to learn ourselves. Like Erin said, our overall goal is to improve really the culture of the payer-provider relationship for the patient.
Excellent. And with that, we have Gigi, who has a question, and you may speak.
Hi, it's Gigi, and my question. Hi, Erin. My question is regarding over providing services. So you're getting audited, and you're participating in an IOP program that doesn't allow billing for ancillaries, but records are then requested, and you have provided services outside of the traditional 3 hours a day for IOP, but you're not allowed to bill them because it's all inclusive. How do you fight that in an audit?
So that's a really good question. And we do see this sometimes. I can tell you the areas where we really see the pitfalls versus the areas where we haven't seen too much trouble. In an IOP setting or PHP setting where outpatient services are being rendered, it's not unusual for us to see additional services outside of the 3 programming hours. A lot of times, we might see that some of these services would be non-covered as an ancillary, or there may be, let's say somebody's participated in 5 hours a day. Usually we would see that there would be 1 or 2 hours where those services may be non-evidence-based, and the payers have no problem with those additional services being rendered, because a lot of times we'll be able to find a few things that may not be evidence-based or maybe investigational or experiential in nature, like a yoga or a, acupuncture session or something like that. Now, where we see the pitfall would be where somebody is receiving residential level of care, but they're actually being billed at a PHP level of care. So when there's a difference in whether or not it's in an inpatient or outpatient setting, that is where we historically have seen the biggest problems. So, this is something that we definitely have seen before, and we've seen the most problems with Cigna going back and Optum doing clawbacks when people have been receiving a clinical level of care on an inpatient basis, but they've been being billed for an outpatient level of care. Now, the payer recommendation in those situations, let's say, as clinical director, you don't believe that the patient is ready for a step down to PHP, but the insurance company thinks they need PHP. As a clinician, you think they require residential. The insurance company recommendation is that those days would be non-covered and that you should be receiving money from the patient or the family in order to cover for those residential days.
Okay, my experience was with Aetna saying PHP was provided, IOP was billed, even though it was technically an ancillary service, they did claw back that money.
What was the ancillary? If you don't mind
it was stuff like you were talking about, like yoga and equine therapy outside of regular IOP hours.
Yeah, in that situation, we would have put up a pretty big fight. I think that there would be a lot of ground for you to stand on in order to contest that recoupment request.
Yeah, their reasoning was the client wasn't allowed to experience life as he should have been, given more freedom, blah, blah, blah. We're taking our money back.
Interesting, because usually Aetna is also one of the friendliers. So if I'm actually interested in learning about your experience offline, because that's not something that we've seen at the lower levels of care, and it's also not something that we've ever seen with Aetna.
No, it was Cigna.
With Cigna. Okay.
Yeah.
Let's see, Sergey report.
Yeah, it was a large audit, something to do with Florida fraud, and
yeah,
anyway,
Cigna.
yeah.
So Cigna did a lot of these post-payment audits, and I would say that they have been the most problematic in scrutinizing providers for delivering more services than what have been authorized. But in the same breath, Cigna will also quickly, if you only had done equine therapy and yoga and, one evidence-based group, they would say that you have to give them a refund as well. So, I think that we need to there are ways. This is a revenue arm from Cigna. It's nothing more than, I know this is being recorded, but our experience is that Cigna regularly conducts these post-payment audits as part of their strategy for revenue. And our experience has also been that we've seen refund requests from Cigna nearly 7 figures, $800,000. Usually we're able to negotiate those down to a really reasonable, amount. So, I would just encourage getting additional resources and help and legal opinion on navigating those situations, because that's something that you're going to continue to see.
Okay. Thank you, Erin.
You're welcome. Okay, I've got another question here. I'm gonna, I don't know if everybody can see it, so I'm gonna narrate it. If I'm a business owner and one of my clinicians' documentation had been found to be unsatisfactory, but the clinician has already left the team, how do I handle this? Ooh, it's a good question. We've seen this. Listen, I expect that out of the 130 people that are on this call, all 130 people will have documentation that does not meet the standards that we've discussed. We know that to be true. We live in the world of reviewing charts. Our recommendation is that if you strive for this and you find yourself meeting 80%, then that is a really good place to be. So we would say, if you have a clinician that's no longer with you, but their documentation was horrendous, there's not really anything you can do going backwards. But what you can do is just commit and document, create a memo internally and circulate it that you guys have internally identified this, or maybe not even identified, but you guys have internally been proactive in having taken action to hold each other accountable for better documentation going forward. And usually in an audit situation, if we can, meet with SIU at the payer and say, listen, from June through December, we had X, Y, and Z happening. In December, and this problem was identified, an initiative was taken, and there was a corrective action plan that was rolled out internally. And you'll see that from December through April, that this problem no longer exists. We can have them expand the scope of their audit to look at the more recent charts as well, so that they can see those corrections. So, my recommendation is that commit to just doing better going forward, circulate some type of an initiative internally around, compliance or quality, and make sure that there are policies in place for those chart audits.
And I would double down on what Erin said, they want to see you taking action. So a system for peer reviews for each other to look at notes is a really good one. And this is what I tell my clients that have some, charges that are going in front of a judge. You always want to present an action plan, because if you leave it up to them, you might not like the action plan that they present. So it's always good to come up with your own to solve your own problem.
Right. And I see from Sergey, he said, as a CEO or program director, you're responsible for those notes. Yeah, absolutely. But we have programs that have 700, 1,000 beds. So, the CEO of those programs are not able to review 700 or 1,000 charts every day. So it's really imperative that there are policies that are rolled out where there is some type of a peer, like Patrick said, a peer review program, or that you have a really detailed plan on what quality looks like in that setting. And that there's also a feedback loop. I think a feedback loop is important, so that if you do have a repeat offender, for somebody who's consistently just their documentation is falling short, they're not signing, whatever it might be, that there's a feedback loop in place so that you can hold that clinician accountable.
And I think that, and like what Sergey said, so the CEO and program directors, responsibility is put the system in place. And you hear so much, oh, they're such a great therapist, but they're awful at notes. Well, if you're awful at notes, it didn't happen, right? So like, how do we help this person? You know, how do we educate them? How do we hold them accountable? Because documentation is the key to all this stuff, you know? And so the things that we would do, we would have staff pizza party peer reviews, right? And so once a week, we'd give them pizza and spend an hour of like kind of just collaborating and go over notes. It doesn't have to be a process of like this grueling thing at Friday at 8 p.m. I'm just drudging through everybody's notes. It can be a learning experience, and you could do it collaboratively where people can learn and ask questions and improve at the same time.
Yeah, another thing, Patrick, that just like reminded me, that is of, you know, what we've seen that works well. Oh my gosh, I lost it. It was a really good idea too. Darn it. It's going to come back to me. Peer review, audit.
Was it because I said pizza?
I think pizza distracted me from my idea. I absolutely think that had something to do with it. Okay, it's going to come back to me, but it was something we've seen in practice for, oh, I know exactly what I was going to say. So yes, sometimes we'll see that some of your, and it's not uncommon that somebody will come to us and say, we have this therapist, she's incredible. Her clients love her, but her documentation is subpar. And we see this on the medical side as well. Like we see this all the time in hospitals and in surgery centers. So what we recommend is that you can have a scribe. So you can have somebody who's assigned for basically being the person who's documenting everything that's happening. And then they're basically like an assistant or scribe to the clinician, and the clinician goes through and records it all. So this is not unusual. You can use transcription services. You can have, you know, documentation being dictated and then have a transcription service actually chart the documentation. So if you have clinicians who are really, really good at what they do, and you want to be able to salvage them as part of your program, there are always additional options for using additional resources to capture that documentation.
And Sergey, thanks for saying that. We are seeing in healthcare and behavioral health a lot of emerging AI documentation. So it is interesting to see that. And you know, here at Hansei, we're exploring stuff as well for documentation. But there is a lot of good stuff out there that can really help use the technology. Duriel, how's our time look?
Yes, we have about 5 more minutes, pardon me. If anyone else has any more, oh, well, looks like we've got something from Victoria. Being a solo practitioner, can you send those programs that you recommend that helps audit documentation?
All right. So Victoria, I think it's going to be kind of, as a solo practitioner, I think it might be easier. You know, what we would really recommend if you're just an individual practitioner is just templatizing the services that you're doing. So whatever electronic health record you're using in order to render your services, we would recommend just templatizing that in the form of that GIRP note, so that every single session is just getting documented in a standardized fashion. And if all of your session notes are following that template, then you should have no issues at all. As a solo practitioner, I think some of the EMR solutions that we see in the space would be too robust and would be kind of overkill for your needs. We would probably recommend just taking, you know, anything as simple like a Dr. Kronos or, you know, therapy notes or whatever it is, and just templatizing those sessions that you're rendering. I hope that's helpful.
Yeah, I would also say being a solo practitioner can be hard, you know, at times, but, you know, we were talking about the peer coaching. So you don't necessarily have to hire a peer coach, but maybe you could partner with a peer coach and you guys could provide services together. We've seen people do that. We've been seeing people, you know, bundle packages with peer coaches, you know, for a longer period of time. And then also, you know, always seeing if you can find an intern or with a local college or somebody that would, you know, could definitely help with documentation and audit and stuff like that. Like, you know, when you got to get those hours. So that might not be a bad idea either. I like Sergey. Sergey, we're going
Yeah,
to send you
Sergey.
a job application. I like
We
it.
didn't,
Let's
we
get 'em.
didn't get into the IMRs. So, an IMR would be an independent medical review. And he's right. So we would see that if you are operating, like even for the scenario that Gigi described earlier, if you have somebody who is being rendered, who's receiving services at a higher level of care, I'm gonna move my hand over here, a higher level of care, let's say you're a residential and the insurance company wants to see them at PHP. But we believe, your utilization management team believes, the clinical director believes, the doctor believes that their symptoms are substantiating them to be at a higher level of care, then we would take the risk and take that through the denial process. You have to usually go through the insurance grievance process, get the denial, go take it to peer review, lose the peer review, take it to, the appeal, the expedited appeal, lose the expedited appeal, and then we can kick it over to the IMR, which is the independent medical record review. This varies from state to state. So I think it's important to say that Sergey's coming from California. In California, the IMRs that are being conducted through the Department of Healthcare Services or the Department of Insurance, we are seeing an average denial overturn rate for between 60% and 100%. For his program at Summit Estates, they're at a 100%. Sorry, I don't know if that needs to be anonymous, but they're at 100%. They also have a tremendous resource for being able to submit these IMRs. If you are, if you have the luxury of being able to get opinion letters from addictionologists who are well-versed in ASAM, and you also have the support of the patient, we feel confident that you too would receive a 100% overturn rate with these denials by following that IMR process.
And I was going to say, as we wrap, as we wrap up in the end, just think about this. You're the expert and you're the advocate. So like the first time somebody says, hey, give us all our money back, the appropriate response is no. Like, let's just slow down here. I mean, if you're ethically providing services, the patients deserve to have the services and you deserve to get paid for the services. So, be confident in your approach and be confident in what you're doing. And, and if it comes down to it, looks like call Sergey because, you're providing a service and you deserve to get paid. So, and like Erin said, a lot of the times when the insurance companies contact you, that's a separate part of the insurance company whose only job is to get money back, right? So, and that's where the collaboration can help. But, we are the advocates for ourselves and we're the advocates for the clients and we deserve to get paid for these services.
Yeah.
Right.
So, Sergey just said, we're kind of talking to the masses here, everybody from solo practitioners to people who are clinicians for 1,000-bed programs. Sometimes taking it through that full IMR process is not necessarily an option if you're operating a high volume Medicaid program where you also probably just the dollars spent in actually trying to complete an EMR would exceed the dollars received in reimbursement. So there is a cost benefit analysis. But if you have good relationship with the parents or patients and you've got the patient advocacy component and you also have a really good medical resource, we would recommend taking it through that denial process and then submitting it to be overturned.